Thank you.
Yeah, my pleasure. And I know that Sarah Bramlett, our grant liaison, is going to be coming from another meeting, but she will be joining us, as will Marianne Raimondo.
Oh, great.
Yeah,
Back to where it all started.
that's it. That's it.
That's a nice surprise. That's very nice.
Yeah, I thought so too.
Hey, Cheryl. Good to
Hi, Adriana.
good to see everyone. Wow, this is good.
Good afternoon, it's Denise.
Hi, Denise.
Hey, Denise,
Hi.
how you doing?
Good, how are you?
Good.
Lori Jordan, you look very serious. I mean, yeah.
No, I'm not that serious, trust me. So, no, I was just under the gun. I drove to New Hampshire this morning. I'm taking care of a friend's farm while their kids get married. So literally, I'm like pulling into the yard at like 5 minutes to spare going, I gotta get on Zoom, I gotta get on Zoom.
Well, you did it.
I did it.
And you might see some familiar faces from South County when you did the program over there. We've managed to capture Kim O'Connell and Brett Davey.
Oh my goodness, aren't you lucky? That's wonderful.
Yeah. And Michael, yeah.
Michael Lighton.
Yes, he's coming on Monday.
Oh my God, I can't tell you. There are no words to capture how much I adore that man. We actually became friends after he was in my class. That was that's what brought us together. Yeah. And he's just a superb human being. So you are just blessed all around, my friend.
Thank you. We're very happy.
Just getting pictures of our chat there. Make sure all of our colleagues are on. I don't want to start. I don't know if, just for our cohort group, I don't know if folks heard from Melba, but her mom was in a car accident. So she had to leave. And she's hoping she was going to the urgent care. So she's hoping to be able to make it back, but if not, I know that that she will submit the beginning stages of the project that she had started working on for PCHC administration to consider. But she did reach out to us earlier today to let us know.
Thank you.
You're welcome.
We'll be in our thoughts.
No. All right, so let's see. So I thought we would go with the order that we've been exploring the last class, and then also with the invitation. So we have our BlueStream going first, and then we have the outreach group, Jackie and Adriana. All of those folks looking at what we've learned about why people are still coming in even when they are not symptom-free. And then we have Carla and her team talking about the implications for staff safety. And then if Melba is able to join us, her project really was predicated on the findings of the work that her colleagues were doing. And so her area of focus is on paperless patient registration as a way to promote quality care for patients and staff safety. And so each group has presentations prepared. They have handouts, and I'm sure, will you guys make sure that the handouts get sent after the presentation to everybody? Is that possible? All right. So I'm just checking time. It's about 2:04. We'll get started in 1 minute. I want to just remind folks of the kind of Zoom protocols. So we will all remain muted, especially as our groups are presenting. And then I believe that there will be some time for question and answers at the end. I will make sure that I'm keeping track of the time, and I will send out a chat to folks in the team if as you're getting closer. We had planned for about, kind of on the low end, about 15 minutes, and then with questions coming into it. And so we'll just kind of be mindful of that. We have an hour for this meeting. We can go to an hour and a half, but I do believe that there may be some PCHC staff meetings or something later this afternoon that are competing with this time. Is that right, Jackie? I might be mistaken, which would be great because then we have a little bit more time. But I do think the 2 to 3 is probably a perfect size window for what we have in store.
It might have, Tanya and Charlotte, might have been the ELT meeting, and we've moved everything to accommodate.
Oh,
So
perfect.
we're free.
Thank you. All right, perfect. So that's wonderful. So one of the things that I want to do just as a start is you're going to get a chance to meet all of the PCHC staff who were part of the leadership cohort, but I want to make sure to introduce you to our training team and the folks that have worked really hard to partner with PCHC, and especially the really talented people that made up this combined cohort of the initial cohorts 1 and then 2, and came together under very difficult and challenging circumstances that I think most people would have run screaming from. And it's a testament to their commitment and their dedication and their stubbornness not to give up on something that they stuck it through. And I have to tell you, I am really inspired by the projects that they've put together and the meaning that they hold. So let me start by introducing our team. I'll start with myself. I'm Tanya Glantz. I'm the director for the Institute for Education and Healthcare here at Rhode Island College. And I have the great pleasure of being the PI on this health system transformation project grant that has made it possible for us to provide this training to Providence Community Health Center staff, which we hope is the beginning of a very long-term relationship. And we've certainly had to get creative over the last 5 months. And that's an interesting journey that we'll have a chance to process a little bit today. I'm going to go next to Tiffany. I'm going to look at my screen and just go right across. Tiffany, do you want to introduce yourself?
Sure, I'm Tiffany Word. I'm the research assistant on this project, and I'm just here to help in any way I can, and it's been an absolute pleasure.
Rich? You just got to unmute. I don't know if I can unmute you. Yep. Oh. You're still muted. I'm not sure why.
Okay, am I unmuted now?
You're perfect.
Okay, I want an introduction. My name is Rich LeClaire. Welcome everybody. It's my pleasure to be part of the team. I was responsible for 4 of the module trainings, and I participated in the development of the various presentations and the projects as best we all could. So it was a great opportunity to work with all the staff, dedicated staff at Providence Community Health Center.
Thank you, Rich. And last but not least, Lori.
Hi all, I'm Lori Jordan. I am a professor at Rhode Island College, and I also taught 4 of the modules. On the front end, I had the privilege and pleasure of being able to teach face-to-face with folks and getting to know them a little bit before we moved online. And I also, helped kind of guide their projects and provide support wherever I could. So I'm very eager to see the final presentations. I know the group worked very hard.
Excellent. And the person who will be joining us shortly is Marianne Raimondo, who is kind of the brains behind the whole idea of putting together a leadership practicum and certificate program. And Marianne was with us for 2 sessions where she talked about quality improvement, aim statements, and then she came on after that and provided some additional responsiveness to areas that, that folks were interested in getting more information on. I want to, before I turn it over to start out the presentation, I wanted to just take a second for some acknowledgements. First and foremost, I can see that we're joined by the leadership at PCHC, and I welcome you, and if you'd like to let us know who you are, certainly your staff know, but you're new to us and we're really thrilled to have you. So it'd be great to know who we have with us today.
Hi, my name is Patricia. I'm actually the director here for Capitol Hill Health Center.
Excellent. Welcome, Patricia.
Thank you.
Cheryl Perry, I'm the Vice President and Chief HR Officer, as well as recently marketing.
Excellent. Thanks, Cheryl.
I am Kim O'Connell. Oh, go ahead, Ray.
I usually just hang up when I'm trying to unmute myself. I'm Ray Paris. I'm the Executive Director for our Accountable Entity Program here at PCHC, and there's 3 or 4 folks on this program that report to me, and I learn a lot from them every day, so I'm anxious to learn more.
Excellent. Thank you, Ray. Kim?
I am Kim O'Connell. I'm the Chief Transformation Officer, PCHC. Happy to be here. I'm really looking forward to the presentations today.
Excellent. Thank you, Kim.
Hi there.
I'm Brett
Susanna
Davey.
Conklin.
I'm the Director of, sorry, Susanna. I'm Brett Davey, Director of Marketing and Communication at PCHC.
I've started to think of Brett as one of our team because he's been on the last couple of calls with us. So I'm glad you identified yourself in a multiple context there.
I'm on anything Adriana asked me to be on, I'm on.
That's a good person to follow. Thanks, Brett. Susanna?
Hi, I'm Susanna Conklin. I'm the Chief of Staff here at PCHC. I too am very looking forward to this. I think it's so exciting to be able to see what our team has in store.
Excellent. You're going to be very pleased. And last but not least, our critical liaison there, Jackie Scuncio.
Hi, I'm very excited and happy that these are the troopers that stayed with us through this entire process during COVID. So thank you very much.
Yeah. Thank everybody for that. And that's the last acknowledgement that I would like to make before I hand it over to Sharon and her team. So the way that this process began, it began January 15th with us coming together in a lovely setting, Saved by the Bay, Save the Bay, Saved by the Bay. Maybe I need to be saved by something, I don't know. Save the Bay, and it was also kind of accompanied by lovely refreshments. I don't know if people who were there at that January 15th, the same thing happened when we went live in, I believe it was March with our second cohort. And it was just lovely, the environment. There was openness. People were talking about the type of communication that they wanted. And then once COVID happened, things really went flat for a little bit. We were trying to figure out how quickly is this thing going to go away? What can we do? It became apparent to us relatively soon that not just for this relationship, but all of our relationships needed to be accommodated with an online presence. And that was a place that we were looking to grow. But the college, like so many other organizations in Rhode Island and across the country, were planning on slowly growing in that direction, not having to do it overnight. And so I'm grateful to the folks on my team who worked very hard to take a curriculum that is very meaty and dense and requires a lot of different levels of interaction and finding ways to separate the curriculum to make it accessible to people. And I'm even more grateful to the staff at PCHC who, while I was Zooming with folks from my backyard because I couldn't work in my office, you had people going into your clinic settings, people dealing with staff crises, having to cover for multiple staff being out. And they still managed to, despite all of the juggling that they were doing, they still managed to show up every week. And it said something to me about their commitment to their organization, said something to me about when they start something, they finish it. And then it also said something to me about your organization. Sometimes the way you package something, people can be very rigid, and this is how we do it. But I have to recognize Jackie Scuncio in this, her ability to really stop, reflect on what was going on, be open to pivoting. And then there were some points that were really frustrating for folks in this cohort as they were, dealing with staff shortages and having to cover all of these different things. And Jackie at no point said, that's it, we're not doing it, or this is the way we said we're going to do it, so that's how we're going. She demonstrated the leadership that I now come to recognize in all of the people who've been in this cohort. And Jackie really gave us the opportunity to say, you know something, there's something bigger than what drove us to do this cohort in the first place. We have issues of a pandemic. We have issues of social and economic justice that are leering in our communities, that are affecting our staff and the people that we serve. And we can't afford not to acknowledge them. And with that, Jackie really allowed us to stop and have the staff really focus on where they were at that point in time and the work that they were doing. And as a result of that kind of flexibility, which I think is the earmark of a great organization and even greater leadership, your colleagues here today put together presentations that are very relevant to this pandemic that continues and appears like it will be continuing for some time. They've put together meaningful assessments, in some cases opportunities for intervention or recommendations for what we might do that address the organizational impacts of some of the chaos and crisis that surrounds us right now. They've addressed it at a patient level, trying to really understand opportunities for outreach and really trying to not make assumptions about why people are or aren't doing things, but finding out from those people what's going on. And then most importantly, in order for you to continue in the way that you have, you need to be able to count on your staff. And so many of the folks in our cohort stopped and really looked around to see how the staff were being impacted, especially by the pandemic, and what it meant for servicing patients, for maintaining their own safety. And so they've shaped their presentations today around all of those issues. And for me, they're all interwoven. What we learn from one has implications for what we can use to inform the other issues that are going to come up. And so I welcome you to really take it all in. You'll get copies of their presentation. I want to thank Sharon, who shared the template that PCHC uses for its projects to give us kind of a nice common platform that was PCHC relevant. And so you're going to get those materials in that format, and you'll also get a copy of them through the email, and we will have opportunities to stop and ask questions at the end of the presentations. Any comments or questions before we pass it over to Sharon? All right. So I'm going to stop sharing, Sharon. I'm going to give you the screen.
Okay. Thank you, guys. All right, let's see. Is everybody able to see the screen? Yes, cool, awesome. So Tanya, a quick question. Does everybody have in the team have access to move the slides, or do I need to do that?
If you're sharing from your computer, then you would be doing it. If you want one of your colleagues to do it while you speak, you could just have them screen share, and you can talk and they can advance for you.
All right, I'll just advance for everyone then.
Okay.
Okay. So who's up?
That would be me, Lillian.
Could you just tell us who's on your team?
Sure.
Thanks.
Absolutely. So my team, we did a project on telehealth via using BlueStream. Project team members consist of myself, Lillian, Denise Andrade, Dan McGuire, and Sarah Hill from IT. And so our presentation basically is about telehealth, and each of us have a kind of a component within this presentation today.
Well, thank you everyone for your time, and I thank leadership for taking time with their busy schedules to be here with us. I will begin with saying that this was lots of fun, and it was a great collaborative with my teammates. So as Sharon said, Our project involves the telehealth via the BlueStream platform, and we have a tagline here: providers hate me or hate us, and patients think we're just okay. As she mentioned, the team members are Denise Andrade, Sarah Hales, Sharon Joseph, Daniel McGuire, and myself. Just to give you a quick background, in March of 2020, telehealth services became billable in the state of Rhode Island in response to the COVID pandemic. And in April 2020, PCHC selected a telehealth video platform called BlueStream. In May of 2020, PCHC began piloting this platform with Express, integrated behavioral health services, and dental providers. PCHC initially tested the free version and later purchased the full version to better integrate interpreting services with the same platform, as well as the ability to capture patient images during the provider assessments. Providers basically providers that can actually use BlueStream include primary care, IBH, case management, asthma, allergy, dental, dermatology, optometry, podiatry, and myself here in pharmacy. Any patient who basically has a cell phone or a computer or a device can actually participate in the video telehealth visit, and all members of the care team play a role in having a successful telehealth visit.
Hi, this is Denise Andrade. So the project overview is, BlueStream was a new tool for PCHC providers to engage in video calls with the patients. And as part of the Leadership Academy, we identified an opportunity to examine a new tool in the early onset stages to try to give some feedback on its usage. So to do that, we obtained feedback from the providers and patients. We used surveys. We evaluated the experiences and the feedback provided by those providers and patients about using the video platform. And then we used the information to help develop a strategy to further the adoption of this platform and to maybe make recommendations to improve it. So our global aim, it was to identify the areas of improvement when using BlueStream for patient care. And specifically, we wanted to identify the level of provider satisfaction. We wanted to improve the patient satisfaction, which is really quite high at 90%, but we felt maybe we wanted to increase that to 93%. And also to develop the recommendations to improve the overall adoption and satisfaction with BlueStream for both the patients and the providers. Dan? I believe Dan's next, right?
Yes.
My sincerest apologies, Dan was on mute. So we reached out to all the providers, and 26 of them were kind enough to share their opinions of the BlueStream system. And broadly, we were asking them 3 types of questions. What works and what are the pain points? How's the technology working? And how are the workflows and processes that we've been built around the technology working? Next slide. And first, if we look at the technology, the answer is pretty good. The way to read this is stuff in red and yellow are folks who are dissatisfied or extremely dissatisfied. Green is satisfied or extremely satisfied. And what you can see here is that plus or minus, the people who are dissatisfied with the system rank less than 20% of all the providers we spoke to. That's not bad for a new system and new processes, all things considered. I do want to bring attention to the video quality thing. That brings up the first appearance of red for extremely dissatisfied, but also take a look at what happened on the right side with extremely satisfied. There are a lot of people who think this doesn't work, but there are even more people who are very excited about the potential here. And I think what that speaks to is a combination of technology considerations and process considerations that I'll talk about a little bit more, and we can talk about in more detail later in the presentation. Next slide. And when we talk about processes and workflows surrounding telemedicine, the story is relatively similar. In fact, we see even better responses on sufficient time, speaking freely, making assessments. People plus or minus like, or at least don't hate, the experience of having a consultation over telemedicine. Where we start to run into some bumps is the process of actually using BlueStream. And again, we'll talk about that a little bit later. Next slide. We also gave providers the opportunity to talk a little bit more about what their overall experience is with the system and kind of illustrate things with some notes. And I think what comes out the other end as video connectivity, as we looked at earlier, is a major differentiator of this technology versus the pure telephonic stuff we were doing earlier. And what emerges is people like video when it works. People do not like video when it doesn't work. And our hypothesis, and again, we'll talk about this a bit later, is that there are a series of technical issues on our end and on the patient's end, particularly around bandwidth, that impact the effectiveness of video conferences. But when they work, it's a great way to see a rash. It's a great way to see hydration. It's a great way to see breathing. And these are the sorts of things we'll have to keep in mind. It's a new way to have a visit, and we need to keep in modality in mind. I think the other thing that came out of this as we look at benefits and barriers, and we've seen this and talked about this as we talk about behavioral health, is that some patients who are formerly non-compliant love telemedicine. I don't have to leave the home. I don't have to think about transportation. I don't have to think about childcare. All of a sudden, I'm having a real conversation with my provider. Is it as good as a full-time visit? Perhaps not, but it's occurring. And that wasn't necessarily always happening for these folks before that. In addition to that, there are some technical and process issues we need to work through. There's a real focus on English that we're working through and we'll talk about later. But also, we've typically involved caregivers and interpreters and other individuals in our in-clinic sessions, and we need to make sure that the new technology we're dealing with accommodates those kinds of workflows because it's important. The other thing is provider and staff enrichment. This is a new technology. We've done some training, but given the magnitude of the change, the way we deliver care, the number of pieces involved in making that care happen, it's critically important that everybody be comfortable with the tools that are being provided, and people learn in different ways and in different rates, and we need to respect that. And I think finally is workflow optimization. I think this reflects the diversity we talked about earlier, which is that folks who are techno-savvy think it's the best thing since sliced bread. People who are not real comfortable with technology or running into issues want to throw their phone out the window. So I think there's an obligation to us to do some remediation on that front. And then there's some additional workflow stuff about how this interacts with the EMR. Next slide.
The next, can you hear me?
Yep.
Okay, great. So the next part is talking about patient survey questions. So we had the Crossroads group, who is actually not associated with our Crossroads, it's an external patient satisfaction company, and they asked questions about how the, sorry, there's noise in the background, how it pertains to video telehealth. So the question is, how would you rate the ease of connecting with the care team via the telehealth video system? For this telehealth video encounter, were you able to connect with a member of the care team within 15 minutes of your scheduled appointment? And how would you rate the overall quality of the care you or your child received from the provider? So the first one is the ease of connecting with the care team. So you can see overall, the results are very, very positive. So, you can see the data there. It's, almost 50% for good and excellent, and only 2 responses for fair. And then the next one is about connecting with a member of your care team within 15 minutes. And, again, you can see that the responses were excellent to good. And also it's, they responded slightly better, saying that their connection via video was better. So, next slide. And then the overall quality of care received, connecting to their care team within 15 minutes. And again, this is these specific statistics are about video and rather than phone. And again, good to excellent overall is the next slide. And
great. Well, thank you, Sarah. So based on our provider survey and information that we've obtained from our patients, we looked at recommendations in each of the bucket areas that we've identified. So in terms of the troubleshooting with the connectivity, we know that's a large issue. One of the things that we have just enacted is when a provider is having issues with connecting via video to the patient, is in the end of the session, there is a survey where the provider can document the patient's phone type, the specific issue that was experienced. A lot of times, providers have reported getting a gray screen. Most of that issue has to do with, on the patient side, not allowing the application to use their camera. And if the patient gives PCHC's IT permission to reach out to them to help them troubleshoot in connecting to their video. We did put that into place already. So we will be gathering information that the providers put into the survey. We can collect that data and then we can have our IT team follow up with each individual patient. Also recommended developing of a guide to assist the patients in how they set up or prepare for a successful video. MedStar Health was recommended via BlueStream consultants in how we can template their kind of patient assistance guide. So we're looking into that as well. Mitigating some of the patient barriers or some of the patients to using successfully BlueStream. Initially, the text messages to the link to join a video conference via BlueStream was first in English only. We have asked them now to include a Spanish translation as well. So when the providers text the patients to join them via video, they get an English and a Spanish text message to join. In that, they have a link to the patient guide, which is our consent to treat. This is both, again, in English and in Spanish. One of the things we would like to do or recommend is in a text message or somehow getting information to the patient is a kind of like a brief video guide or a brief telehealth video or guide or something that we can put, not only texting it to them, but also put it on our website on how they can connect. And they can kind of pre-prepare for their video visit with their provider. In terms of training and education, developing user guides for our providers and having kind of like hands-on training sessions so that they can practice and get used to it. And also kind of educating the care teams and the members who are using the video every time new resources or guides are being implemented. One recommendation kind of we have about workflow is at the time a HCA or nurse is scheduling the video visit, if we can collect the information on the patient's phone type or carrier and document that into the note section of the EMR, and even asking them if they've had a telehealth visit before, that will kind of give us some idea if they were able to ever successfully connect to a visit via video or not. And in order to kind of do all of these things, we have had to extend our current project team. So BlueStream, the consultants, are actively involved in this. Jay DaCosta, Gerard Rohde, Mike Hosker, Kate Williams, Dr. Qureshi, Dr. Chai, Michael Speary, Dr. Ahn, and Nellie. We've enlisted in part of the testing and also providing recommendations for on their part for improving the system. Looking at success factors, so once we get recommendations and these key actions implemented and start testing them within the piloting phase, you know, well, how are we going to know that this is successful? How do we know if we're kind of improving provider satisfaction and making sure that they're using this? Is, you know, maybe we follow up with a post survey, you know, after we've kind of done all this stuff and troubleshooting and helping patients connect to via video. What are the providers' thoughts and feedbacks now? We'd like to increase utilization at least to 50%. Right now, we're only piloting just with a limited number of care teams. And also we'll see an increase, or hopefully not a decrease, in the patient satisfaction by utilizing the Crossroads group and having them continue to ask those pertinent questions. And this is just kind of like an outline of the key action steps, who would be responsible, and where we are in the status of recommendations and moving forward to make sure that this is successful. Any questions from the groups? Thank you all.
Great presentation by everyone. All did a very nice job, and this was a topic that came up at another meeting I was in several weeks ago, so would have been nice to know all this back then. I could have filled in the blank without asking a lot of questions. But anyways, great project. When do you anticipate this will be in kind of final phase so that it's organizational wide?
We are hoping, and I'll have to have Jay kind of check the box on that one. We'd like to do it at the end of September if we can kind of get everything and collecting the feedback and reaching out to patients. One of the things might take a little bit is kind of mimicking MedStar's kind of resource guide and brand it with our information. That might take, you know, maybe a full 4 weeks to get, you know, signed, sealed, and delivered. And how I think we get that out to patients, whether it via a link in a text message to our PCHC site.
Right.
And
that's wonderful.
We have slowly added, I know a lot of providers have reached out individually to say, hey, Sharon, I want to try this, you know, especially the paid version. Paid version is really, has the ability to link with our interpreting services, and it's really seamless. So when providers are on a video call and, you know, they need an interpreter, and it doesn't have to be Spanish, it's with any language that our interpreting services does, it's an easy kind of connection, and it's really seamless. There might be a little pause, like no different than connecting outside in a, you know, face-to-face visit to get that interpreter on the line. But that's a nice feature and seamless in the whole aspect of that video conferencing.
Thank you.
Can I ask a question, Sharon?
Sure.
I'd like to see what it looks like from the end user perspective, like from the patient's perspective. I think that would help if you included that like in the training modules too, so that folks that are using it understand what the patients are seeing. If it's simply just a text, I get it, but
yeah. In some of the initial training materials that we, Andrew Solomon and I had put together, we did have what the patients see, kind of screenshots for what the patients see. And we've kind of given our piloting providers, I'll call them, you know, a lot of times when the patients get that text message, they're supposed to kind of say allow to the video or allow to accept the consent. And if any of that they deny, the video is not going to come on. But because that link to the video conference or the video visit is doesn't die right after the first click, now the providers are asking the patients to just kind of go off the video and re-click that text link, and then just click allow through that system. But it is in the the guidance documents, but we can also test too. It's kind of fun testing. Then I get to see you.
Added bonus, right?
Hey, Sharon, this is Rich. I had a question and a recommendation.
Sure.
First of all, I think the team has done fantastic work, despite a lot of challenges you had with the regular job and trying to keep everything going. Plus the project, like all the projects, it's very timely. I mean, a year ago, everyone was thinking about it, toying with it, looking into it, planning it in the future, and boom, you had to make it happen within a short period of time.
Yeah.
And then now applaud you for assessing it and trying to improve it.
Thank you.
My question has to do with how did you come up with the recommendations that you're suggesting here? Was this from the team? Did you poll people? How did you come up with a list of possible recommendations?
So not only from the team, but also from our ongoing conversations with the extended care team, the extended project team, as well as weekly conversations or meetings that we have with BlueStream.
Oh, excellent. Okay. My recommendation is if you're up for really challenging yourself, a lot of organizations are measuring the top quartile as key. So when you do your satisfaction surveys, whether you have like 5 boxes or 4 boxes, extremely satisfied, somewhat satisfied, neutral, fair, and all, the tendency is, and I understand it completely, you put the very satisfied and the extremely satisfied and the satisfied together, and the score's pretty high and you feel pretty good about it. Definitely never, I would never put neutral in any kind of satisfaction. That's clearly a dissatisfied, somebody who's neutral about it. But some just test their top quartile. So if you're going to measure extremely satisfied, you measure improvements based on that, because if you can move that group, you're really moving all the other groups. And it's easier to measure moving somebody from 35% to 40, 45% than trying to look at 93 to 98 or something like that. So I would, maybe you don't do anything differently. I wouldn't suggest that, but I would just suggest when you look at your measures, pay attention comparing that top quartile over time, because that'll be an indication of how you're doing. If that doesn't budge or reverts, then I think, although the numbers may look right, I don't think the group is as satisfied as you'd like it to be. That's
Awesome.
just a suggestion, pure suggestion.
Thanks. Thank you for that feedback. Any other comments, questions before we move on to the next presentation? Well, thank you all. We appreciate you allowing us to participate in this Leadership Academy. It was a great experience.
Thanks, Sharon. Great job. Great job to your team.
Yes, they did an awesome job.
All right, so next we have Adriana's group. And are you guys going to show your slides, or would you like me to do it for you?
Tanya, can you hi, it's Chelsea. Can you make me the presenter, because I'm doing the intro? So I have the slides right here.
Yep. So you can just share your screen.
Okay.
There you go.
Okay, so good afternoon, everyone. We're here to talk about our project titled Evaluating Patient Education and Community Awareness During the COVID-19 Pandemic. And this is our lovely team. So Adriana Vargas was the lead for this project. She's the Director of Community Relations. And then myself, the Manager of Community Integration, SDOH Strategy, and Maria, the Assistant Health Center Director at Capitol, and Jackie Williams, the Front Desk Supervisor at Capitol. So to provide a little bit of background about our project, we're going to start with the current state. So Providence residents, including PCHC patients, have been greatly affected by the coronavirus pandemic. And a majority of the patients that go to Providence Community Health Centers live in the Providence area and the urban core cities across Rhode Island. And so as you know, many of you have probably watched the news or listened to the radio, you've heard headlines titled, Low-income communities hit hard by the COVID pandemic. Latino and Black neighborhoods struggle with test disparities and things like that. And so the pandemic has more negatively affected poor, more densely populated neighborhoods with higher rates of racial and ethnic minorities, like Providence, for example, with the second highest rate of positive cases at 16% behind Central Falls. And so why does this matter? So as of August 8th, PCHC patients accounted for about 3,000 positive cases in Providence, and 15% of all positive patients, in Rhode Island utilize PCHC as their patient-centered medical home. And when we look at the data across this state, and we look at the prevalence by each city and town, we included the top 5 cities. So starting with Central Falls at 19% of individuals that tested positive for COVID, followed by Providence, North Providence, Pawtucket, and Woonsocket. So according to the CDC, factors that are associated with more COVID-19 cases, hospitalizations, and deaths in areas where racial and ethnic and minority groups live are really the social determinants of health. So housing, for example, do our patients live in close quarters? Are they living with multiple family members in the same household? Are they unable to isolate if they do contract COVID-19, then spreading it to their family members? Occupation, do they work as a frontline staff member? Are they essential workers? Do they work at grocery stores and restaurants and hospitals and health centers and have high contact with individuals that could potentially have COVID-19? And they might be unable to quarantine due to their type of work and not being able to work remotely. Education, do they speak English as a second language? Do they not speak English at all? Do they have any type of literacy barriers, unable to read and write? Healthcare access and utilization, do they have insurance? Are they afraid to seek care because of their immigration status? So the CDC recommends that in order to prevent the spread of COVID-19, we need to work together to ensure that people have resources to maintain and manage their physical and mental health, including easy access to information, affordable testing, and medical and mental health care. And so for our approach, in order to address some of these factors that I previously mentioned, we conducted a patient survey to learn more about where PCHC patients are getting their information from regarding COVID, such as the radio, TV, social media, and what types of barriers they have on accessing this information. Do they have cable? Do they listen to the radio? Do they have a cell phone that works? Do they have a language barrier? So the overall goal of our project is to improve our patients' access to information about COVID-19 through effective messaging and communication in order to increase their compliance with the COVID-19 guidelines and minimize the spread of the virus, thus protecting PCHC patients, staff, and community members. And so for the objective of our project, it's to use the results that we learned from the survey to inform our community outreach and communication strategy on useful methods of getting information to patients during the COVID-19 pandemic and in future health crises. So now I'm going to turn it over to Jackie to talk about the key components of the project.
So the key components to our project were planning, developing survey questions, requested reports of patients to outreach. Dan's team helped us with that. Also requested approval from the executive leadership team. Then we also communicated with Ralph and the HCDs to let them be aware that we were going to do the survey and also outreach to the patients as well. Recruit staff to assist with conducting surveys, administer surveys, analyze data, prepare presentation, and present. data collection process. So we sampled about between 8 to 15 patients per health center, randomly chosen from a list of patients seen in the last 3 months. Ages were 18 plus, languages were English and Spanish, 10 questions, multiple choice survey, and the method, surveys were administered by the outreach team, Maria Ramirez and Anastasia Paralitici, and Norma. And so these were the survey questions that we had asked the patients. And so included in those are the demographics were the age, zip code, race, ethnicity, language, and primary health center. So the first question was, what do you and your family do to stay safe during COVID-19? Where do you get your information about COVID-19? What sources do you trust to learn about COVID-19? What barriers, if any, do you have to accessing information about COVID-19? And what specific COVID-19 information would you like to learn more about? Now I'm going to turn it over to Adriana to discuss practice and awareness.
Thank you, Jackie. Actually, there was, she just described some of the indicators, which was knowledge and practice of safety measures, sources of information, trust, barriers, and also resources that patients might need during this COVID period. But before I continue, I want to thank everyone in the team for really working so hard in doing this, presenting this project. We initially thought we just needed to present a proposal, and then we found out that we really needed to do it. So, so we have to do it pretty fast. So we might have to do it again. So next, please. Can you, okay. So the first 5 questions actually refer to the demographics. So we pulled the information from our patients database to avoid having to ask too many questions to the patients. We surveyed 102 patients from all of the health centers, with the exception of the med school. So in terms of ethnicity, I know I don't have my, oh, I can point. Can you see when I point? I don't think so, huh?
No, I'm pointing, Andrea.
Yeah, okay, so in terms of, yeah, that's right, because you're doing it. So in terms of race and ethnicity, the white Caucasians accounted for half of the surveys. However, 60% of the total surveys were conducted in Spanish, if you want to see it right there. So PCHC report actually grouped race and ethnicity together. So as we know, these are 2 different questions. So we actually, some of the actually white Caucasian are also Hispanics, because, the race and ethnicity were all in one. So probably having more accurate demographic could have resulted from inquiring directly from the patients. But, pretty much we did reach who we were looking for. Next, please. Oh, hold on. I'm sorry, go back. So in terms of age, there was an even distribution of all 4 age groups. And also, we look into the zip codes, and the highest number of patients surveyed were from 02909, which is Olneyville, 02907, Elmwood, and Elmhurst, which are actually the 3 zip codes with the highest COVID-19 incidents in Providence, Olneyville being the first one, Elmhurst the second one, and Elmwood the third one. Next, please. So when questioned if patients practice the COVID safety measures, all 3 predominant races and ethnicities reported they do practice the 3 given safety measures, which is wearing the mask, social distance, and washing hands. And the other choice, around 17 of the comments were really related to keeping the social distance, and some of others talk about the disinfecting and other people taking care of themselves, of their health, with diet and vitamins. The next one, please. In terms of source of information used by the different ethnic groups, so we look into this data by ethnic groups and also by age range. So, and I will talk about what was the answer based on the ethnicity. So as you can see, the TV was the most popular information source, Hispanics having a strong preference for TV among the three groups. Internet was second most popular among all ethnic groups. Hispanics, once again, rating internet higher than the other groups. As you can see also, family and friends also played a key role for Hispanics in getting the information. However, if you look at the graphic, all of the ethnic groups use other sources for information. So we need to look into that as we consider developing a plan. Next one, please. So in terms, I'm sorry, Tanya's message. Oh, okay. So in terms of sources of information used by the different age groups, so the T as the ethnicity group also rated high as a source of information across the ages or the age ranges. However, internet, as you can see, was most popular for the 18 to 35 group as expected. Internet was also second highest for all age groups. So it is important to notice that PCHC and family seem to average out to the third most popular source of information. So here comes PCHC. Next one, please. So we looked also not only where they were getting the information, but we wanted to know if those were also, what were also the places they trust the most. And I have to say that in this slide, you're going to see Rhode Island Department of Health, which I will say that we have asked these questions at the beginning of the COVID. I will say probably by April, this will not have that higher rate because DHH really came along, DOH really came along within the past 6 weeks, very aggressively reaching out to other populations. So, but if we look into the based on ethnicity, Hispanics rank TV as the highest source of trust, followed by DOH and Facebook. And in an average, DOH was most trusted by the three ethnic groups, as I mentioned to you now. So we should mention that PCHC also plays a role in terms of trust among Hispanics. And also, as you can see again, data shows that Hispanics were trusting more sources than other races and ethnicities. The next one, please. So in terms of age, 18 to 50, so actually, the yellow and the red colors, which are the 18 to 50, consider DOH as the highest. I'm sorry, I have a little bit of sources of trust by age. I think I have the wrong information here, but let me see. So TV, I think I already mentioned that TV is actually considered one of the highest in the internet. Oh, actually go to the next one, please. Oh, I already discussed. Hold on, I think I got a little bit confused. Can you go back into the next one, into the sources of trust by age groups? So as you can see, TV was also considered the highest, and internet mostly for the age. I think I already mentioned this slide. Is everybody paying attention? Yes, I did already mention that also PCHC staff and family are also considered as sources of trust. Actually, you have the wrong slide.
So Adriana, I think there's a slide missing because this is sources of information, not sources of trust. So there's sources of trust by ethnic groups, but I don't see the one.
Yeah, I think what we've just made a final change, and I have to say why, because when we look into the trust by age, and I'm sorry, we did, that was the last slide. I made the changes and probably it didn't go into this in this presentation. But anyway, when we look into the age, we notice, I'm sorry that the slide is not there. It got deleted when I was making a change and it was a last minute change. So the ages 18 to 50 actually considered actually DOH as a source of, considered as the highest trusted source while the 16 plus, I'm sorry, is not connected to this slide, but I want to tell you the older the population, they actually trusted more the PCHC, which is not here. I'll make sure we get that. TV news was also seemed to be a second highest in terms of trust. And once again, the 50 to 60-year-olds rated PCHC higher. So out of all the social media, Facebook and Facebook, Twitter, and Instagram, Facebook seems to be the most trusted for all ages group. And I'm sorry once again that we got a confusion here at the last minute. Can you go to the next one, please? So, so when we ask them to identify, what exactly, when you refer to web pages or TV news, can you tell us which ones? And they actually describe that in terms of web pages, Facebook, Google, and YouTube were the ones that their sources. Also for TV, Telemundo, Univision, and Channel 10 were mentioned too. And for radio stations, Poder 1110. Next, please. So I just put this in one slide because actually the results for various by ethnicity and by age group were kind of similar. So the majority of patients with ethnic and age categories responded, they feel they don't have any barriers, believe it or not. Some of them said, we don't have the barriers, we already know everything. So, but as expected for Hispanics, speaking a different language was considered to be a barrier. And we all know that. Technology was graded for the Black African Americans group. However, this group was surveyed at a smaller portion. So I think we still need to and evaluate and assess the barriers because the information didn't really correlate with what we know now. Because it was also surprising to see that technology was not identified as a barrier for Hispanics, since we know technology has been an issue mostly for the elderly population. Next, please. And we also wanted to know, just in terms as we develop messages, and I will actually also work with everyone who is assisting patients during these periods. We wanted to know if they needed more information about how to stay safe, what to do if they were sick, and if they any other trusted information. So in general, all of the 3 residents reported interest in learning more about resources, even able to work, especially the Latinos, the Hispanics, I've been using that, and also all of them kind of wanted to get information about resources, what to do when they were sick. But most of the answers have to do, especially in the tab responses to others, they said, I already know, please don't tell me. And it's especially about the symptoms and about what to do. One of them said, I'm fed up with the information I already know. Of course, we are in the fifth month after COVID started, so it's understandable that they do have all of the information. Next, please. So some of the conclusions, and I know, the survey was done pretty quickly, but based on this information, so we noticed that, patients reported they practice the safety guidelines, but compliance remain an issue, as well as controlling for other social determinants of health. So it's not just knowing and practicing, but there are other things that affect the fact that they have higher prevalence in COVID-19. TV and internet, especially Facebook, are main sources of information for patients of different ethnic and age groups. DOH, TV news, and PCHC seems to be the most trusted sources for patients of different ethnic and age groups. Hispanics depend on Univision, Telemundo for Spanish information. Data shows Hispanics were trusting of more sources than the other races and ethnicities. And language still is a barrier among Spanish speakers. Next, please. although patients reported that they know the information about COVID, patients still would like to get some more information about resources, getting sick, and where to find employment. And although research has shown that faith organizations and radio played a key role within the Hispanic population, they seem to be rated low in this study. And, you know, also from my experience in working with the community and working with the faith leaders, I know COVID wasn't a source. The faith organizations were not really a source of information because they were lost. I had meetings with many faith leaders and they didn't know. They were desperate asking for information, but they are actually a source of trust. So I think we should further, you know, look into this. Some of this, all of these indicators, I think it will be worth to evaluate. So basically, the Pew research shows that Instagram is widely used by the young population, and we found in our study that they rated it very low, but Instagram is actually used by them. Next. And I think next I would like to introduce Maria and to continue with the presentation. And I know Norma, Anastasia, and Maria Rodriguez are in this call. And thank you so much for the great work that you did in doing the surveys with patients. I really appreciate, we all, the team, appreciate that.
Yes, thank you. So some limitations that we have given the time that we had, we felt like our sample size was too small. Maybe if we had a larger sample size, like 350 or so, we'll be able to draw better conclusions or more accurate conclusions. The sample selection, like we mentioned, we only surveyed English and Spanish speakers. So we didn't fully capture our patient population, including like the Cambodian, Portuguese, Quiche population, in addition to others. And the method, the staff from PCHC were conducting the survey questions. So I felt like, well, we felt that people were maybe more likely to be more truthful if they were self-reporting or being interviewed by someone who wasn't tied to the organization. They might be answering to kind of appease us, saying what we want to hear. And the survey instruments, we only asked multiple choice questions with a few open-ended ones. I think we would have gotten maybe different responses if we did a semi-structured interview where people can kind of really tell us their answers, and we might get more variations. And the time constraint, just trying to get we kind of had a short time to do like the surveys. So I felt like we did a good number based on the time that we had. But I think with more time and more surveys, I think we'll get better information. Next slide. Thank you. Some recommendations that we have. So the community health workers are already outreaching about food needs for confirmed COVID cases. They're getting weekly reports from Dan. So we were thinking about maybe consider asking questions about unemployment or employment concerns if they are sick and they can't work and they don't have like, TDI or something like that. So just offering more resources, possibly like a COVID-19 resource packet. Also recommending maybe enrolling COVID-19 confirmed cases or patients in a texting program to provide them, different reminder messages about safety, prevention, where to go, maybe links where they can kind of click for resources. And also recommending that PCHC look into utilizing more maybe messaging or communication via TV and internet, seeing as that seems to be the top sources that people go to for information, also the top sources that people trust for information. And the other recommendation, Adriana came across this during a meeting, right, Adriana?
Yes, yes.
So DOH's goal is to drive compliance with public health guidelines by implementing communication and behavior change campaign. So based on our survey results, we know that patients know what they need to do to stay safe, and staff from a clinic perspective, we're providing education and guidance and screening from every kind of patient point of contact, from the telephone to reminder phone calls to when they're coming into the clinic, follow-up phone calls. But we're seeing that people are, the compliance rates, the numbers seem to, the positive rates seem to keep going up. So we figured, for inspection and reinforcement, and person-to-person engagement education. We're kind of doing those things already, but maybe looking to DOH when they kind of roll out more behavior change campaigns to see, you know, what behavioral science informed type of outreach could help us maybe increase compliant behavior. And that's it. Any questions?
This was a great presentation, guys. Good job.
Thank you.
One of the things I'll add as we get ready to transition to Carla's team is there was a concern at the start of this project that maybe people were coming into the facilities because they hadn't been adequately informed through marketing. And what this team's research, although preliminary, what it helped us understand is it's not that people are coming in because they're not informed about safety practices. They're coming in for another reason. And so looking at some of the other ways to message to them is a real opportunity. And this information, I think, is really critical as we pivot and listen to our last presentation from Carla's team when we talk about what is making staff feel unsafe and knowing that even though people are adequately informed, they're still choosing to come in when they potentially have symptoms and could be positive for COVID-19 and are putting other patients themselves and the staff at risk. Carla, would you like me to do your slides or are you going to?
Actually, Loida is our team lead and she's going to be doing it.
Beautiful.
Hi, thank you. Yes, oh, I actually sent the presentation to Tiffany. She was gonna assist us with the slides. Thanks.
Got it. And I've made it so anyone can share. So feel free to share as soon as you're ready.
Aloyda, you can present.
Okay. So hi everyone, my name is Loida Ruiz. I am the front desk supervisor here at Randall Square. And today we're going to present you an employee safety and improvement plan. We're very excited to present this proposal. I know that at the beginning of the Leadership Academy, this was supposed to be an improvement of a work process, but then when COVID came, then it started being a safety measure. So we know and we recognize that PCHC has encountered a big challenge. When COVID started, this situation has really pushed us all to work, think, and do things in a different way. And we do recognize that the organization has already done a great job keeping the staff safe. And through this project, we wanted to identify new opportunities to improve the safety and make staff feel safer at work. So an overview of our presentation is, I will shortly present the team members. I will go over our objectives, questionnaire responses and results. We'll present to you a paperless registration plan and a conclusion. Our team consists of Carla Kerrigan, the HIM manager, Zulema Gonzalez, enrollment and projects manager, and myself. So the objective is to promote staff's feelings of safety and the ability to deliver care at PCHC by understanding what currently supports security in the workplace, as well as new opportunities to increase safety. I know many of you have heard, many of us have heard the phrase, we spend more time at work than we do at home. And that's why we value and understand the importance of a good work environment, good work relationships, and that's why it's also safety is so important in the workplace. So in order to promote feelings of safety and identify opportunities, we needed to find out how the staff is feeling. And I'm going now to turn it over to Carla to give us more information on how we did to get the feedback from the staff.
Thank you, Loida. You can turn the page. Thank you. So good afternoon, everyone. In order for us to get a good idea of how the staff actually feels about the current safety measures in place, we sent out 50 questionnaires. The questionnaires were sent to front desk staff, health information associates, reproductive health counselors, and enrollment specialists. We were focusing on non-clinical staff that basically have a face-to-face contact still with patients. We are very happy to report that we had a 58% return rate on those questionnaires. Next. Next. Thank you. So our questionnaires, we had all the questionnaires, the questions were open-ended because we didn't want to sway the staff into putting it in buckets of what we thought might make them feel safe. So we left it all open-ended. What do you feel is currently making you feel safe in your job? What do you feel would make you feel, what do you feel would make you feel safer in your job? Kind of a play on words. What can be improved or done to ensure that you feel safe at your job? And then is there any other areas at the site that you feel, other than your current working environment or area, that you feel might need some improving? So next. So the first question we asked, what do you feel is currently making you feel safe in the job? By far, it was PPE and hand sanitizer. The telehealth visits versus live. And then unfortunately, we had 6 people that said they didn't feel safe at all. Next slide. So basically, PPE, probably PPE, let's try again, and hand sanitizer was at the top of the list. They felt that they were getting enough equipment to feel safe. Telehealth visits, they felt that, you know, having that patient have a visit at home versus face-to-face, especially if they're sick, benefits everybody, including the patient and their family. The social distancing and screening prior to appointment. It's very important. I mean, even in HIM, before we make a scheduled appointment to have somebody come in, we screen them and ask them those questions. Have you been out of the state, or have you been international? And have you been screened or tested? And do you have any of the following symptoms? So minimum patient contact, again, was what made them feel better. So next slide. The other questions 2 and 3 we kind of put together. What would make you feel safer and what can be improved? Basically, more hand sanitizer at 28 and temps at 15, and more televisits. That's kind of where the most of the focus was. And it looks like the front desk staff is where people had the most concerns for. Next slide. So when we talk about PPE, it's a little contradicting than the first question, but that's because the first question asks why you feel safe. And they feel safe because they do have that equipment. But what their concern is on this side of the question is that wearing the same mask for a week, or wearing the gowns all day and having to not being able to change them frequently, they have concerns about that. They would like to see more frequency in changing out those items. Taking temperature of anyone who enters the buildings. This is including staff and the visitors, our patients. And there was some questions about getting death shields for the patients. And of course, like I said, the area for most concern are the front desk staff. They spend the most time with the patients. when they do the registration process. So next slide. So basically, what the staff is saying, again, is that the PPE, they'd like to see it changed out more frequently. They do understand that we do have a shortage and that it's really hard to come by and we have to be conservative. But at the other point, you know, sometimes those masks just, you know, get kind of gross. And I think something that we might be able to implement a little faster is temperatures taken at the sites. I know our executive team, our clinical team probably looked into this already, and there are reasons why we don't have that currently in action. So we're just bringing it to you as this is what the staff showed us that would make them feel more comfortable and safe at work. Only because when they go to their PCPs or they go to even some stores, they're taking, you know, the no contact temps, okay? So this is basically what we took away from what the staff, the employees feel. When we were looking at all of this, Loida had come up with the fact that what would actually help them and our patients is a paperless registration process. It would decrease the time that the non-clinical staff and the patients spend together. So I'm going to turn this over to Zulema, who is going to speak about that paperless registration process.
You have your mute. I'm sharing the office with Loida, sorry. Really? F4. Okay, sorry about that. And thank you. Good afternoon. So we talk about paper registration process right now, and it can take at least 10 to 15 minutes to register a patient, and that is if the patient brings all the documents. That includes signing for consents, current care, sliding fees, finish the demographic of the patient, scanning insurance card, IDs, and that is in an adult patient. When you have a minor, then you have the minor consents, birth certificates, ID for the parents, and all that. So right now at this point, we have 10 or 15 minutes in the registration process. And this is really important to have the accurate information for reimbursement and identification purpose. So our goal presenting the paperless registration, it will be that the process will be 3 to 7 minutes. Next. So this is a proposal to implement paperless registrations. It would take the place of the manual signature and the scanning paper. We can send the patients electronically via text or email all the documents that they need to sign for the time of the visit. We can create or have a feature that they can send a copy of the insurance card, the IDs, birth certificates, anything like that. And we're still gonna have couple of the patients that they're gonna wait until the time of the visit because they don't have a computer at home or a smartphone or anything like that. We can offer them the iPad and we can help them finish with the process of the registration. What is good about this? Next. This have the benefits that we're gonna have less contact with the patient. That's gonna encourage the staff of feeling safe, the health and the well-being for the employees and for the patients at the same time. It's gonna be an increase in efficiency and receiving information. And usually if the patient is the one filling out all the blanks, it's gonna be accurate, the information that they're gonna put in the system. So that will be a great opportunity too. Another thing, it's gonna be reducing the waiting time, and we can measure that. It's gonna boost the security and the safety for the patient and the staff. A great outcome for this is gonna be the time management. So the front desk now can concentrate to verify the insurance, so less error for the billing department, and answering the phones. Next. And another thing that you would save in papers, definitely in that. But we need help. We need to include different departments and directors in this process if we want this proposal to be effective and have a paperless registration. We need the IT directors, IT project manager, compliance department, HMN, quality, health centers, directors, front desk supervisors, purchasing, clinical operation. All these teams can get something together so we can have paperless registration. So now to Loida.
So
Loida, we can't hear you.
She's not muted.
I'm sorry.
There we go.
Forgot to take off my mute. So once again, to conclude, we've come up to understand that the staff will be more comfortable with the use of the PPE, being able to change PPE more frequently. No contact thermometers will be very helpful. We understand that the paperless registration will cover all bases for efficiency and safety. And we like this quote very much. We wanted to share it with you. People go to the doctor because they're sick. Do you really want them to be touching pens and clipboards? One of the best ways to prevent the spread of viruses is to collect information remotely. Prevention is the best medicine. So that concludes our presentation. Any questions?
Thank you guys. That was interesting. And I was surprised to see the paperless registration at the end of it. And it's nice that you looped that in. And I wonder, Melba was also going to talk about that. I wonder the extent to which a paperless registration process could be integrated with your electronic medical record, or are they two separate processes?
No, that's the idea. The idea is to have a program where we could take those registration documents and we could text or email it out to the patients, because we do have their most of their email, and we do have access to their text messages, just so that they can get that information together and they can send it prior to. And that way we can look over any documents, we can confirm the insurance ahead of time. And when they come in, it's basically a quick little meet and greet. What questions do you have? You filled out this form, any questions on it? And that way the patient can just concentrate now on the questions they have. They're familiar with the documents. They don't have to stop and think, oh geez, I don't know. This will give them a little bit of a boost. And I know myself, being a patient, I have my doctor's office will send over documents I need to sign ahead of time, or I can take a picture of my license and send it ahead of time. And that way, it won't be forgotten. It won't be forgotten, because you're coming to an appointment, there's a new place for you, and you really might not know what exactly you need. But this way, it'll kind of tell you exactly what you need to bring. It's a physical reminder. And if you have any problems, we'd still like to have, as part of that process, is to have little pads or iPads so that patients can still sign electronically, and the registration staff do not have to worry about scanning it in, because right now it's scanned into different areas, and we're hoping that we can just upload into the category.
Yes. Scanning definitely takes a big amount of time when it comes to the front desk process. Also, like I said in the beginning, because I worked early with the front desk, this was more like an improvement process, for the registration. But then when COVID hit, it also represented the safety part of this process. And I think it is for both sides, for the patients and for the staff. And my train of thought with this, it goes even beyond, because Interior already has a messaging function in it. So if we can already use part of what we have and integrate it, even when the patient logs in to sign their consents and do their demographics, it already goes directly into their patient portal. That's even better. I know, and we did spoke with Jay before coming up with this proposal, and I know this has been in conversations for future plans for the organization. So that's why we didn't get more into detail of how we would do it, because we don't know how far out that's gone. But we did wanted to bring the safety issue into consideration. So maybe it could something that be expedited and have it in the near future for the whole organization.
Ask a question quickly. Just
Yes.
sorry, I mean, I'm missing time there. Thank you for a wonderful presentation. I am curious in terms of the survey itself. Did you sort of stratify the results in any fashion among physicians, nurses, HCAs, front staff? Did you categorize to see where everybody lies?
Yes,
In terms of
actually,
feeling safety? Yeah.
yes, actually, when we're looking at employees, because we know that the clinical staff have very specific guidelines, so we focused on those non-clinical staff. We took surveys to the front desk staff, the staff that even though they're not clinical and they're not practicing clinically, they still have the face-to-face with the patient. So they still have to have a patient sitting in front of them. The health information associates, front desk staff, the enrollment specialists, and several other. So we took those surveys to them and we left it open-ended so that they can actually put how they actually feel. Then what I did is I took that data and I put it together according to the answers that they gave me. I kind of bunked them together, and that's how we came out with our numbers.
Okay, just curious, why did you not include other people?
Well, like I said, I think it was just, we were thinking who can benefit. And when this first started out, one of our focuses was thinking about the shields. And so we were thinking, okay, who would need to utilize a shield? But as we got further into the project and then we did the surveys, we found out that the shields weren't top on anybody's list. It was there and people did mention it, but we didn't have a high rate of people saying, I'd feel more safe if I had one of the shields in front of me like they do at the supermarket or retail stores. So I think that was what we felt our focus was going to be. But then when surveying them and finding out that's really not their top line, we decided that it's best to just capture, because we gave them the questionnaire to capture their true feelings. And we didn't go to every single person like administrative, like billing or any of them, because they don't really have the face-to-face with the patient. They call the patient on the phone, but we actually see the patient in front of us. We make exchanges with that patient, whether it's forms, whether it's, pens, clipboards. So we do that kind of cleaning after. So I hope that answers your question.
Yeah, no, thank you. Thank you very much. Yeah.
You're welcome.
This is Jackie. I was just going to comment on the relevancy of all the presentations. They're wonderful, so timely. So proud of this group for pivoting. And I think that the number of surveys that were done really telling. You took the time to find out what our patients need. Luckily, we had wonderful interns to help out with some of the data collection. Some of you got involved directly yourself. But I think it's so akin and comparable to what you as leaders need to do on an ongoing basis. Find out what your employees need. What do you need for me to better support you as a leader? So I think inherently the work that you did is a demonstration of what a good manager does. Before you take action, find out as much information as you can to make sure you're making informed decisions and actions. Wonderful presentations. Thank you.
Thank you, Jackie.
And nice job, everyone. And one of the things that we learned, and I know we're at the end of our time, but we had started when we were meeting in person to have people frame their projects as a part of the beginning process. And then when we went online, we were trying to get people acclimated to the online learning environment. And so we actually did a pivot about halfway through the online process, and we moved to make the focus on projects. We actually moved more of the material to asynchronous formats, and then started to try to provide Zoom opportunities for people to come together where they were talking about these meaningful work environment issues and able to bring their own expertise and some of the additional skills. And so it was an opportunity to really turn the original program that was developed, I think, by Mary Ann and Lori Jordan, if I'm not mistaken, to take it and turn it upside down and actually use it as a way to really model flexible leadership and having to meet people where they are, like you're doing every single day in your clinics. And so it was challenging at times, trying to have empathy and just trying to find ways to support the staff. But in the end, we kept kind of going back at it. And I think that you've made it possible for us to offer this in multiple contexts in ways that we can pivot going forward to really have it be not just a flat focus on leadership, but meaningful and have it be relevant to exactly what people are encountering in that point of time. And I think your findings will probably be helpful to some of the other community health centers as well, who maybe haven't had the luxury of stopping and thinking about these things. So I want to applaud your dedication throughout the entire process, all of you. Thank you so much. It's been a pleasure working with all of you.
Thank you, and thank you to all of our instructors for helping us and supporting us along the way as well.
I agree with Maria. Thank you very much.
Excellent. So we will be in touch with folks just with updates. I think I have, with the exception of Sharon's team, I have all of the presentations, so I'm happy to package them and get them out to everybody. And we can touch base through email just regarding the final steps of the certificate program. And I hope that all of you get a much needed vacation. Many of your staff here actually met and did their work while they were on vacation. So they didn't use vacation as an opportunity to step away from this. And I was grateful when I heard people were taking vacation. Dan actually said, hey, would it be okay? And I was like, please, you know, you guys need a break. So I hope you actually get to take one now and enjoy a little bit of what's left of the summer.
I noticed that Mary Ann Raimondo is on the line, and I wanted to add thank you for your partnership and leadership with the funding and to the DLT. We are so appreciative of being able to do all this work with some funding.
And Cheryl, we will get the video of this to you. It'll come to my computer, and I'll get that to you so you can share it.
Great, thank you.
Yeah, I joined late, but I'm so impressed with what you guys pulled together, and I hope that the senior team listening will, you know, work with you to move these ideas forward. I too echo what others have said, that listening to your customers and the work you did to listen to your employees and your patients is just impressive. So I agree. I saw Rich's comment. You hit a home run. I agree. Great job. It together. Awesome.
All right. And thanks to the administration for joining us today. And
thanks for having us. We appreciate it.
It was our pleasure. It looks like it's still nice outside. Maybe some people can get a little R&R in after all the hard work.
Great job, everyone.
Tanya, I'm going to send you the correct PowerPoint with the final change, which I thought it was there, okay? Before you send it out.
Yeah, no problem.
Thanks, everyone.
Diana.
Thank you to everyone.
Thank you.
My student intern.
Thank you. Bye, everybody.
Bye, everyone.
Bye. Bye. Bye, guys.
Oops. Oh, there we go. Jackie, were you happy with that? Oh, good. I think you're muted.
All right, very much so. Yes, thank you. I was just answering a Skype from Jay, our head of IT. So once I get the recording, we want to share it with the CEO, and he was just asking if there's if I run into any trouble, his group is happy to help. So it's lovely. So whatever handouts, and if you can get the recording to me, I'll make sure I send it out to the group.
You got it. Yeah, I was taking notes through the process to make sure that if anybody showed anything, that I would kind of have it packaged together. So the video, I'll send you a link to the video. So this way it'll be easily accessible.
Wonderful.
All right.
Okay.
Excellent.
All right, great.
And
well, this is wonderful. I did get the prizes, if you will, surprises. They just got delivered today to the main office. So the pad folios and the pens, we're going to be shipping them to their homes. So I just have to get the right boxes so we can ship them. So they should have them by next week.
That's excellent.
Yeah.
And we're going to be reaching out to them. We did an analysis of what people have progressed through in terms of the actual synchronous work, the asynchronous work. And so we'll be reaching out to staff and letting them know what remaining steps they have to getting the certificate. And then when they get the certificates, I will notify you that people have received them, so that maybe you can, I don't know if you put it in their personnel file or something like that, but I'll make sure that you get a copy of them.
Wonderful. Okay. Terrific.
Excellent. It's been great working with you on this, Jackie. A lot of pivots and bumps in the road, but
we made it through, and our work is not yet done because we still have the third cohort, which will be broken up into 2 sessions.
Yep.
We'll have to get started on planning that out. And because we don't know what January is going to bring, we might have to launch it online, you know, and then as COVID dissipates, be able to bring them to Save the Bay, but more work to be done.
And I think that we'll use the final way that we pivoted with this team to actually kind of package. I liked doing it upside down much better. And I think it was more meaningful for your staff who were just, you know, stressed about so many things. So for them to actually, one of their big fears was, do you know if PCHC will be okay with what we're focusing on? I said, this is what Jackie asked you to do, right? And so the fact that they were heard by their higher ups and that your head of the organization said, let me know what you need and if you run into trouble, that is going to be so empowering for them. Yeah, so that's like the best part of this.
Yeah, I mean, it's human nature with so much going on. With so many things, people feel powerless or they don't have any sense of control. They picked projects that they could maybe affect some semblance of control and help, because inherently they all want to help make it better, but they don't know how. And the projects that they picked are wonderful because it gets to the how and the mode of how we can, you know, formulate, okay, let's get it back together. Let's refocus. Let's affect change. That's good.
And I think the response rates that they've gotten were amazing, especially during a pandemic. I mean, we had no idea if they were going to get much. And that data, I think, is going to be critical for years to come. So.
Absolutely. Yeah. And just a plug for Melba. Melba was working on Carla's team. And because she kept being short-staffed, she was having to run the front desk. So she wasn't able to go and meet with them on a regular basis. And so they made the decision that she didn't spend enough time with them and they didn't feel it was right to include her in the project. But the project she brought to the process was that paperless patient registration. And so she had prepared today, taking all the data from the other groups, saying, here's a good argument for the paperless. So I was surprised and excited that that Carla's group had woven that into one of the recommendations. And I will make sure, I'll share with you the stuff that Tiffany and I worked with Melba on her presentation.
Yeah, and so was she was she solo or did she have someone else
She
on
was by
paperless?
herself. In the end, she found herself by herself, so she didn't think she'd even be able to present. And I said, you know what your problem is. And we
Right.
told them, you don't have to have it finished. It might be posing an opportunity to
Sure.
consider. So that's where she
Sure.
was with her project.
Well, definitely, if she has a, you know, a document in
Yep,
terms
she
of what
does.
her ideas are, definitely send it along
Send them
because,
along.
and she should put her name on it, you know, ideas developed by Melba.
Yep,
I mean, the
exactly.
fact that she persevered
Yep.
and she, you know, she didn't feel like an outsider, but again, that's another demonstration of humans and how they work and
Yep.
interact. Sometimes there's one person who was like, hey, who am I, the redheaded stepchild? But
Right,
she,
exactly.
the reality was she had to be in her clinic, and we know she's in Onlyville. She's in
Yeah.
the clinic with the highest rate of COVID. So of course she can't make it.
So she prioritized her work, which says
She
an awful
did.
lot, and she still found a way to fit this in.
Yeah.
So I'm very impressed.
Yeah, so it's still, you know, even though the voices can't always be there, making sure the voice is still heard. So another demonstration of how it can be done.
Excellent, good. I just wanted to make sure that you knew how hard she worked.
All right, thank you for that.
Thanks,
All
Jen.
right, all, we'll talk when you're ready to reach out to talk about the next group.
You got
Let
it.
me
I'll
know.
give you a couple of weeks break and then we'll get back on it.
All right, very good. Thank you, ladies.
All right,
Bye.
Bye-bye.
Bye.
Coffee's okay.
Do you want to debrief it all, or are you good?
Yeah, let's just do a quick touch base. My daughter just brought me, this is my friend Tiffany.
Hey.
So Ella just brought me a coffee, but she was locked out of the building because
She
now
is a-
you can't go in the front. You have to go around the back.
Well, you're a very good daughter to bring coffee, so.
I needed it. Yeah, I think that went, if you had told me after that one blow up that we were going to get to this place, I would have been like, stop lying to me, Tiffany.
That, I did not expect Jackie to be like, let's talk about cohort 3. So that was clearly a win.
And the fact that she said, we may have to start online, I'm going to advocate for that.
I know. So,
Yeah.
but yeah, when I was watching the presentations, you know, I had so many thoughts of just like kind of what you were saying, just putting everything on its head. And I mean, not that anybody has time for it right now, but like redesigning the curriculum.
I totally agree. And I think redoing, maybe redoing all of the materials, you know, like Lori's 1 hour narrated things, like chunking them out. I think that's the way to go. And just quickly as an aside, that training thing. So, what I'm going to do is I will send you, and I got to make a note, I'm going to send you an MPO7 at the trainer rate. You'll fill it out. You'll send me an email saying, you know, you approve it. And then I'll put it through. Mary Ann's waiting for the dates. But I thought it would be kind of good to get you on that docket of things. And so we'll just decrease however many hours that training takes for the preparation and delivery. We'll just decrease those hours from your 19 with me. So this way you don't violate the cap, but however many you can get at the $50 an hour or whatever it is. That's great.
Yeah. Okay. Well, because I guess now, like, since this is done, like, the time I'll spend would be on like new ideas for the curriculum.
Right. Yeah, and I guess we have to send out the evaluation. And maybe you and I should, maybe we should meet and talk about that, because maybe it's not the retrospective in the way that we had originally envisioned it. And then I also think maybe doing a follow-up, putting together a survey for the senior team, because they're all going to get to see that piece. So it's like, you know, what was your goal at the start of this? How did the finished projects? So we're just going to redesign it, but at least we'll get that first set of data for cohort 1.
Okay.
So send me some times that don't interfere with your day job. And if you're ever up for like a socially distanced brewery where the table is in the parking lot, and just kind of getting together and talking it through in person, I would be down for that.
I'm also on board for that. And so the ride thing, you think early September, mid-September, late, just so I can dream?
Yeah, let me look it up quick because, I saved the chat. I saved the chat as another artifact in our data. I've been doing that on all of my online training, saving the chat. Let me just quickly pull up her the email from Rosemary Shamat. Can I tell you, I would have felt badly if Melba came and they kind of stole her thunder. So there could have been something else going on. Maybe they felt like they were doing all the work.
Yeah, I don't know. So Loida had started messaging me, and she, poor thing, was getting so nervous. And she was like, wait a minute, we were the ones doing paperless registration and la la la. So
so it kind of worked out.
Yeah.
So let's see. I'm just looking to see where her logic model, partnership, grant summary. I'm going to forward this to you just so you can, I'm going to send you the grant summary. Copy. I'm going to also send you the Providence School Health Needs Assessment, which is where some of their data came from. And I can send you, let me just send you what I sent her.
Okay.
Because my understanding is that it was going to happen, the notice would be in the early fall. So it should, it really should be, we should be hearing.
Okay.
All right, so I'm gonna give you copy. Let me go to the inbox.
Although I do feel bad that we just ended something and I'm like, hey, what about this? We should be like, yay!
Can I tell you, I'm sorry. I'm kind of like panicking because, like people are dropping like flies here.
What do you mean? Like leaving?
Well, like they had 120 something layoffs at CCRI.
Yeah.
Right. God. And then, and we're waiting for the college here. So like, usually we have, even like having graduate students do like some of the help on projects. There's nobody here. 462. Hold on 1 second. Tanya Glantz, can I help you? Hi, Dana. Good. You know what? I'm just wrapping up a Zoom. Can I give you a call right back? What? Oh no. All right. I'll try and give you a call back at 5 of. Would that work? What's your number? Yep. 0561. I think that's what I saw come up on my work phone. I will give you a call back in 3 minutes. Thanks. Bye. They want my budget on their grant, but I haven't done it because I can't guarantee that I have the right information. All right, so, and then I'm copying one like crazy long draft document just so that you can see, kind of what the bigger proposal is, and ignore it if anything in it is just like, oh my God, all these, it was a draft, but this way you can kind of get a sense of like the plan and where your position would fit in. Okay. I'm not finding anything that has the date, but I know it's a federal grant and typically by like September, October, you find out. Okay. So I can reach back out to her and see if she's heard anything. But just know that like you're on my radar for that. So hopefully, you're not having a horrible time in your job, but that you're kind of eager to maybe come back over to this side. 100%. Of that.
Well, thank you, and yay for PCHC.
I know we did it, Stephanie.
Good.
Oh my God, thank God.
All right, well, you ladies enjoy your coffee.
All right, thanks. Take it easy.
Bye.
Bye.